Okay, that should be working now. Test, test, test. I think that's working. If anyone is logged in, could you please just put a comment in the comment section that you can hear me okay? I can't actually see on this platform how many people are logged on, but we'll push ahead. So we're just getting draped in. I'm getting my gown on. We're doing a bilateral tibial crest transposition. Jess, can you please read that comment? Hi. Could you just, whoever's there, just let me know that you can hear me okay? Perfect, thank you guys. Can I get some gloves please, Jess, number 8? Perfect. So I think we've got a few of the regulars tuning in. So we have a little, actually interesting, it's a 20-month-old little kind of cavoodle type dog, bilateral medial patellar luxation, and I've been postponing this dog's surgery for a couple of months because his growth plates are not completely closed. His tibial apophysis has got this weird kind of lucence in the tibial crest, but I would have expected it to disappear by now. So we're going to have to be really careful with our pin placement to make sure we get up high enough above that area, which I suspect is going to be kind of just unmineralised tissue and not very solid, not going to have great ability to hold on to the pins. But we are doing the surgery today because the owner is very concerned the dog's clinical signs are getting worse. So generally with patellar luxation, I like to, if I'm doing a tibial crest transposition, I like to wait until the tibial apophysis is completely fused onto the tibia. And that normally happens at around about 12 months, sometimes 14 or 16 months in a small breed dog. Thank you. So we're getting draped in. If anyone has any questions, obviously feel free to let me know. JL, how much does the dog weigh? Dog weighs about 8 kilos, 7 kilos, yeah. Yeah, so we're looking at the tail. I'm going to get you guys oriented once we actually get draped in, and I can move the leg into the kind of camera view. So we're just draping in now, we aren't starting the surgery just yet. So I did kind of start the live stream a bit earlier than I normally do, just to try and get a chance for everyone to kind of log in and have a look. We've got two of our old-time nurses here today with us. We've got Raylene and Jess, who I've worked with for many, many years. They've both given me greasies now, because I mentioned them. Raylene's doing an awkward laugh. We're going to get her on soon. I don't even know how long I've worked with Jess for, but it's probably like 100 years. 11 years. And Raylene probably about the same, 10 years, yeah. In April. Wowzers. Old skill. Yeah, we'll do the checklist, please. Perfect. Bilateral MPL correction. Great. Yep. We'll need an electric handpiece, pin driver. I think I'm going to use cerclage wire. Pin cutters. I think it looks like you've got everything there. Shouldn't be much intra-op I'm worried about. Low. Yes, please. So just do a checklist. We do a checklist for every one of our surgeries, and it just goes through the same questions every time, just to make sure that everyone is aware of what's going on and we're not missing anything. And it's absolutely, I think, an important thing to do, especially when you're doing a lot of surgery and there's a lot of different people kind of involved with cases and there's handovers and things like that, because even with the best intentions, things do get missed. So a very, very good thing to do to ensure you're not making any undue mistakes with things. Okay, we'll take that one down. So if you guys are a member on our YouTube channel, I'm going to put up a case a bit later on. Really interesting disc rupture case that I operated today and picked up from one of our other surgeons yesterday. It was a dog that basically had, I think, just a chronic disc extrusion and degeneration, but basically had collapse of the disc space and subluxation of the vertebral bodies. The dog's neurologic condition deteriorated really rapidly, initially quite slowly over 2 weeks, but then really rapidly in the last 48 hours, and then actually lost deep pain last night. So I operated him, did a pediculectomy and corpectomy, and took out a bunch of disc material from the canal. I couldn't actually tell on the CT scan if it was disc or potentially tumour or maybe discospondylitis. I thought it was most likely going to be degenerative, which it probably is. And then we ended up having to do a fusion of that space. It was at T12-13, so a really interesting case. And I'll put some imaging up on the CT scan after we finished in here. No IBAN. So our YouTube membership, you guys aren't aware, so we've got a paid membership channel or area where we're going to kind of host all the video content that we put up. All the streaming that we do will remain free while we do it, but then once we kind of finish in the surgery, we're going to put it onto the paid membership area. We're also going to do a lot of short videos, just kind of running through case assessment, clinical examinations, CT, X-ray interpretation, that kind of stuff. So lots of clinical information that would be very useful for you in practice, and stuff you can take home and use pretty much straight away. So if you have any questions about that, just let me know. So a couple of questions, very good questions. What grade of luxation and what clinical signs is the owner really worried about? So great questions. The dog has grade 2 medial luxations, and the owner's worried. I'm not that worried about the dog's clinical signs, but the owner is worried. It's kind of hopping and skipping a bit more, and it's extending its back leg out like it's kicking. I'm not that worried about it, but the owner is quite concerned that things are getting worse and quite eager to get the surgery done. And I'm not sure, given that the dog's 20 months old, how much more that tibial apophysis is going to change on x-rays. It's a bit of an unusual looking x-ray. So just getting all of our equipment open. There was another question there. JL, so are you planning to do just the trochleoplasty, or just do the tibial tuberosity transposition? I'm going to get into the joint and then assess things. Look at the cruciate, check the depth of the groove. Most likely I'm going to do a trochleoplasty as well. I'm going to get the little guy. But we'll get in there and have a look. This guy's also had a CT scan to have a look and make sure he doesn't have any femoral varus or torsion. And interestingly, he's got a torsion, femoral torsion, his femoral anteversion angle is 0. It should be about 15. And I'm going to not do anything about that at the moment, but if we do this tibial crest transposition, if he was to have persistent luxation after the surgery, then I might come back and do a distal femoral osteotomy and get rid of that torsional defect and straighten that out. Yeah. Did you manage to let Sarah know we're getting started? Yep. Yeah. Have we got number 2s? Or even 1s? So this is the leg we're going to operate. Chest, oh god. Jess, can I please get some more gloves? So we're just trying to get this in the middle of the screen. I'm just changing gloves. As I move the light, I just touched the edge of the light handle. Can we take that light handle off too, please, Jess? All of them, please, Joe. No, thank you, Ray. That's right. Just grab the edge. Okay, can you guys see that okay? Looks to be pretty good. So we're about to get started. Just going to get my section sorted out. I'm still waiting on my assistant who's on the phone. But I think we're going to get started. Yeah, did we give bradycardia? Yeah, I don't know why it's 68. Do you think that's real? It's not really got asystole. I think it's just reading small waves. If it needs more atropinal glyco, we can do that. Of glyco? Seems to be going up and down a bit. Is blood pressure okay? 80 on 30. Is that accurate though, do you reckon? See what I'm about to start cutting. We'll see what happens once we start cutting. Okay. So there is a question there, which I'll try and get to. Jess, can you read it out for me? Another one before that.
Is it too early to tell a luxation in 1-year-old not painful but clinical grade 3 out of 4?
It's a good question. If it's 1-year-old, my kind of cut off is not so much a number in age, it's more about when the tibial apophysis is fused onto the tibia. I don't need either of those.
And what size
What size what? Probably 19 or 20 gauge. So yeah, 1-year-old age, normally the tibial apophysis is fused on, but I would definitely take x-rays and check. So if I'm doing a tibial crest transposition, I like that proximal tibia to be completely mature. If it's a grade 3 to 4, grade 4, like it should be a pretty clear diagnosis. Like that's when the patella's out all the time, it's not going back in. So if you're able to get the patella back into the groove, then technically it's a grade 3. And so those ones I would generally operate everything over a grade 2. So you guys should be able to see this okay. So to get your orange, I've got patella, tibial crest. Just shout out if you're watching and you can't actually see something. Patella, tibial crest. I'm going to make a lateral approach here from just above the patella, coming down, just kind of craniolateral, and then down adjacent to the tibial crest. So just getting a couple more things open. And I'm working solo today. Let me try and get this position a bit better for you. We're going to work here. Jess, can you just try and move the camera a little bit so you can see what I'm doing here? So we're going to do a tibial crest transposition, most likely a trochleoplasty. And then we're also going to do a fascial imbrication as well. So I'm just coming down through the skin and subcutaneous tissues. And now what I'm going to do is kind of come down through the subcutaneous tissues under the biceps fascia. And that biceps fascia is actually going to insert right on the tubercle of Gertie right here. So I'm going to come down through here. So you can see we've got through that fascia there. It's waking up a bit.
Yeah.
You need like a fentanyl serum.
Yeah, you can have all of
Okay.
I think the incision might be out of the screen.
Okay. That's a bit better. So what I've come through the skin, I've gone through the biceps fascia, so you can see the biceps fascia here now. I'm actually going to get my scissors underneath here, just going to create a space under there, because later when we come back and do our imbrication, that's where it's going to be. So I'm just going to come through there like that. I'm actually going to come down and just take that biceps fascia off the tubercle of Gertie insertion. So that's the biceps fascia here, and that's going to be quite important to make sure you kind of close that back up. So now we come through there. I didn't actually show you, so I'm going to check my alignment here. So in a neutral kind of position, I can see that the patella is sitting on a slightly medial location relative to the trochlear groove. And we're going to be able to feel this patella luxating in and out, just there. So as I internally rotate and move it and extend it, I can see that patella kind of moving in and out like that. Okay, so it's a grade 2, wants to stay in most of the time, it can go out, and is causing the dog a clinical issue. So just going to come through the joint capsule now, you can see a bit of fluid there. We get some gelpies in here now in the joint. I'm just going to extend my incision in this joint capsule a bit further ventral, like that. And now I'm looking down at my groove here, which has got a reasonably good amount of depth. I'm going to do a Dropleoplasty though, as I do them in most cases. So the way I do this is I kind of mark out where I'm going to put it with my blade, and I do a wedge Dropleoplasty. So I'm going to mark it out, my cut in the articular cartilage with a 10 blade. Same on the other side. Like that. And then the way I do these, I use an oscillating saw. I don't like to use a... Can you just scroll down just see if there's any more questions? Any more questions on there? Can you guys see that?
They're all saying respectfully, your head is in the way.
Sorry, that's not the best camera angle. It is a big head. Okay, let me see if I can fix this for you guys. I'm going to bring that over too. Oh, Jess, can you just stop that from tipping over? Okay. Okay. So I'll try and keep my big head out of the way. So we're going to make our cut in our tibial, trochlear groove here. I'm just using this oscillating saw. Can we get an idea how far Sarah's away from? I need someone in here.
Just on the phone for United. 5 minutes?
Yeah, I need someone like...
She's actually lying.
Okay. Hey. That's all right. So just making this cut on the other side of the chop there, just getting a bit of smoke here as I'm doing this. So I'm trying to keep the thing irrigated. Just make sure you guys can see. So I'm trying to get this in a position where you guys can see it. It's just proving to be a bit awkward. And as I cut through here, I'm just going to make sure I don't disrupt my segment and flick it onto the ground. So that's our osteotomized segment that we can see there. Pretty small dog. And I'm going to put that in saline. We got an assistant here now. So Sarah, can you kind of work out where this is going to be in the camera? Like right there, and just hold it kind of there. And then I'll know where I need to work from. Good?
Yeah.
Let me jump around this side. Can we get that like that? Yeah, that should be good there. So now I'm just going to make this a little bit wider. So I'm going to maybe stand here and try and stay out of the light as much as I can. And can you maybe hold that? You can see I'm just shaving off a very small amount of the bone. Doesn't need much to make it wider. I'm going to do the same on this side. Make sure you guys can see that. Okay, so this has all come out pretty clean. Sometimes you get a bit of roughness in the bottom of the groove here that we've created. I'm going to come back and put my tibial crest. Where's it going? Segment back in. So you can see my segment in there now. And you want to make sure that's sitting in there pretty solid and not going to rattle around too much. So I think that looks pretty nice. I'm just checking down now, looking at my depth, and I'm happy that we've made it a lot deeper. Jess, one of our nurses who I've worked with for a long time, does like to make fun of me, and she's taken a photo of the comment about my big head. So that's all right. So now we get the patella back in, and that's tracking pretty well. It's still not, it's still wanting to come out pretty easily. And as we look at our alignment, we're just looking at that tibial tuberosity and where that patella is inserting and how far we want to move it over. So it should be pretty clear. So I'm going to hold that leg there. Let's roll it over a little bit that way, Sarah. Maybe go a little bit more like that, like that, like that. Maybe like that. Right there. Right there. Perfect. So now, what I'm going to do is take the craniotibial muscle off the tibia. So I've cut through the biceps fascia. I'm going to kind of extend that incision along here. You can cut the tibial crest from medial to lateral or lateral to medial. I like to do it from lateral to medial, so I'd take the craniotibial muscle off the tibia. So I'm just coming through and elevating that. And I was talking before about this dog having a bit of a funny shaped tibial apophysis or tibial apophysis where the growth plate still had a bit of an issue. So I'm going to be really careful with how and where I make my osteotomy. This is about making a good surgical plan and then actually executing what you want to do. So I've looked carefully at the tibial crest and the morphology, and Jess has actually pulled up the x-rays for me on the imaging software that we've got. I can't show them to you very easily right at this second. But I'm just taking that craniotibial muscle off. This is the tibial tuberosity here, and I'm coming all the way back. We're going to have long digital extensor tendon back there. but I'm going to get that all the way off. I'm going to have my Homan in there to kind of reflect that craniotibial muscle, and then I'm going to make my osteotomy in this location here. So we'll try and turn that around. I think the angle is going to be best like that, so something like that. And then really internally rotate that guy. So keep it 90 degrees, that's perfect. So it gives me a really nice shot at it with the saw through here. And I'm actually going to mark out a little bit where I want this cut to go, so I can feel the bottom of the tibial crest here. So then I don't kind of get trapped looking at something else and make a cut in a funny position. So I'm going to get some more saline here. And it's important to make sure we make this cut perpendicular to the leg. So I'm looking at my orientation relative to everything that we're holding. I'm going to start my osteotomy here. Just if we can flip it around like that so I can see it a bit better. That's it. Okay.
Can you give me the flash?
Do you want to do that and I'll hold that? Maybe I'll do it that way. And you'll notice I'm sawing all the way through proximally and I'm coming down carefully in this distal segment here. And I'm going to actually leave the very distal segment of bone attached so that I can actually flex that bone. So you can let go there, Sarah. I'm going to push that over. Hopefully we can push it over a little bit here. Yeah, it's starting to mobilise. What I'm going to do, so I've got all this soft tissue intact on this medial side of the joint. And I'm actually going to incise through some of that adjacent to the proximal aspect of the osteotomy, so just in here. And I'm doing that so there's less tissue impinging on my movement of the tibial crest. So now we can see that's moving over there pretty well. Are there any other questions there, Jess? No other comments about my big head? Okay. So I can feel here, it's hard to see it, I'm going to be sure that you can't see this very well, but we've got a bit of a step here, so I can see I've moved that tibial crest over a little bit already. It's still very well attached down here distally. And what I'm going to do, we're going to use probably 045 pins, I would imagine, Sarah. This is a good little trick that I'm going to do here. So instead of putting this initial pin through the tibial crest to kind of assess everything, I'm going to put it on the medial side of the crest into the tibia, and it's going to hold the tibial crest in a lateralized position, and it'll allow me to run the leg through a range of motion and assess if I've actually lateralized it enough. So lateral to medial cut, that's just the way I do it. Some people go medial to lateral, I go lateral to medial. I like to preserve as much of this soft tissue distally on the medial side as possible.
Oh, because that's the side that has the forces.
Yeah, I just feel like it comes back together a bit nicer for me. So I'm going to put this pin adjacent to the tibial crest, there. And then we're going to have a look at this now and assess this alignment. So before we could get that patella to come out pretty easily, and I'm pushing on that, like I can get it out, but it just wants to snap back into place. So you can see that as soon as I push on it, it's coming back in. even when I internally rotate the tibia, it's still wanting to come back in. So I'm really happy with that neutral position. It's very snappy. Wants to come in there, and you probably can't tell very well through the camera, but where I've moved this tibial crest over to, it's much better aligned with the location of the trochlear groove. So I'm pretty happy with that. We've moved it over probably 4 millimeters, I would say, maybe a bit more. Can I get another 045 pin? So the technique, this is just a tibial crest transposition. I don't know that it's got any other specific name than that. And what we were mentioning before, if you guys were tuned in, so this dog's got a bit of a defect in the tibial crest about here in the tibial apophysis. So I'm going to actually be very careful with these pin placements to make sure I'm above that. He's got quite a low insertion point on his tibial crest, so I'm just being very mindful of that. So I'm directing this pin, I'm feeling the fibula and the femur on the medial side, and I'm going to be directing it just distally a little bit, so I don't penetrate into the joint. I'm also directing, instead of just being in the sagittal plane, coming slightly over, so I'm directing it from lateral to medial. Okay, so I'm going to start this first pin. And you can just feel it penetrating through the other side there. So we're going to get one more pin, and it's really important to make sure you don't sort of turn this tibial crest into Swiss cheese. So now that first pin's in there, so by putting pins in and out, so if you put a pin in that, you have to move it, then reposition it, you're going to have like a bunch of holes in there. It's a fairly tenuous piece of bone at the best of times, so I like to give ourselves every chance that we're going to be okay. Now this pin, I'm going to go kind of perpendicular to the first, and it is quite high, so I've got Sharpie's fibres just below here, and so these are going actually through the proximal tibia, distal patella tendon, but it has got a fairly low insertion point on this tibia, as I said, so I'm just going to come in this direction here, and this is intentional because of the morphology of the proximal tibia in this particular case. So I can, with my finger right at the back there, I can just feel those pins penetrating through. I'll just back that one out a smidgen. The other thing you can do is actually just visually check. I don't know if you can see that. So if you look at the end of the pins there, I'll get a shot on the camera, you want them to be about the same length. So if you've got the same length pins before you start, which you should check, I know they're all the same length in these guys, when you put them in and they've just penetrated, they should be about the same length sticking out this side, which obviously makes sense. So I'm really happy with that. Happy we've got a lot of soft tissue attached down the bottom there. Happy with that. Happy with that. Just debating about a cerclage wire. It's a little dog. So my decision making, it's a little dog. I am doing bilateral. I'm a little bit worried about the strength of the bone just because of that apophysis. So I like to sort of err on the side of caution with these things, so I'm going to put a cerclage wire in here.
Pin for that? Or a drill bit? What do you want to make your hole?
Oh, that was a question for me. Let's get a pin. We're going to use that wire. Here, what have we got there? 20 gauge. We'll use 20 gauge. Yeah, let's get an 054 pin, please. We still got the spoon. That's still ours. So just waiting on a few more implants and we'll get underway.
Talk about the different patterns of wire.
Talk about what?
The different patterns of wire. You can do 2 pieces, 1 piece.
Oh, yeah, I would never do 2-piece. I think that's a silly thing to do.
Good talk.
Good chat. So Sarah's trying to get me to talk about different patterns for the cerclage wire. And while there are different ways to do it, you should do a figure of 8 and you should use 1 strand of wire. Good discussion. So I've just used a pin to make a hole in the tibial crest. Oh, sorry, proximal tibia, I should say. There's some little ones there as well, but we can just cut that there.
That made it too big.
Okay, so we're going to go up on one side here, and we're going to make a little twist in the wire. And then we're going to come on this side here, and we're going to actually tighten this on both sides. So I do know that there is a discussion about when you do this, whether you should actually go under the patella tendon. So on this side, especially when you're putting these pins above the Sharpie's fibres, or whether you just go around the pins on top of the patella tendon. I've always done it on top of the patella tendon. The risk, theoretical risk, is that the wire can potentially cut through the patella tendon as it goes through range of motion. Touch wood, I've not seen that happen. And with this location, I think it would be pretty difficult for it to be a meaningful kind of issue. I'm going to actually twist this the other way. Because of the width of the patella tendon in this area and just the way this wire is going to sit down. So as I'm tightening this, I'm kind of pulling back on my needle holders and getting a nice even twist on the wires.
You changed your direction, was that so it matched the direction of the
Yeah,
other side?
change the direction because I always do these clockwise. So if you ever have to take them out, I know that I've always done them up clockwise, so when I undo them, I want to undo them anti-clockwise.
All these times to take them out.
Sarah, I was once a resident that had to take implants out. Thank you very much.
I do actually appreciate it. I take that back. I appreciate you. Yeah, you're going to do it in the opposite direction. Just to...
Yeah. And I'm going to bend these in a bit to make the profile a bit lower. I'm not really worried about them loosening too much. It's not like we're putting it in as a cerclage wire. It's a tension band. So there's a question about selecting the size of the wire, and that's a good question. Off the top of my head, I don't have the kind of absolute recommendations that are out there. I use the kind of wire that looks right, if that makes sense. So it doesn't want to be too big, not too small. I generally, this dog had two 045 wires. And because I'm putting a cerclage on here, the cerclage is actually going to take a lot of the force. So the pins are actually not critical in terms of the strength. The cerclage wire is really the thing that's counteracting the pull of the quadriceps muscle. So it's pulling down, the quadriceps pulling up this way. The pins are less important when you're using a wire. So you could have probably done 054 pins in this case, but I'm going with 045s again because I want to keep the holes as small as I can in this size dog. And I'm very good at just going ahead and doing things without talking to you about what I'm doing. So I've put the wire driver on here to bend these. I'm putting a little kink in it up the top, and then I'm pushing it down to kind of get the wires to sit nice and flush against the cerclage wire underneath. I'll actually just bend that one over a little bit more. Okay. So there's a comment there. Ricky's tip was pick the size that you think looks right, then use the next size up. That makes sense. You do want to be careful though that you don't overdo it because again this tibial crest is a fairly fragile piece of bone. So that's really good. I'm happy with that. Everything's aligned. It's nice and snug. And we are going to now do a lateral implication here. Can I get some saline, please? And the one thing we didn't do actually, Sarah, is just check the cruciate ligament. So just have a quick look at that. Can I get a send retractor? So I was just saying to Sarah, we didn't check the cruciate ligament. So you should always actually check the cruciate ligament, make sure it's not damaged. when you do these guys, so I can have a good look in there. Everything looks nice. And there's really not a lot of effusion in this guy, so Sarah's looking in there as well. I don't know how we're going to be able to see that on the screen. So, can I get some 3O PDS, please? Oh, so this.
Just wondering, the spleen will come in here, so timing with you guys for maybe the CTs and stuff.
Yeah, so the orthopedic wire, so the question was that the pins and then the orthopedic wire. So the orthopedic wire, I do think you should absolutely take the size that you think looks right and then go up a size for sure. And it's more important to have that wire, the tension band wire, bigger or oversized rather than undersized. The most common mistake we see when we see revisions on these cases is that the tension band wire is far too small. So I'm just closing the joint capsule here. My assistant's just talking to the nurses and distracted, so she's not holding onto my leg. Oh, she's back now. Do I ever do a distal femoral osteotomy at the first surgery is a question that's come up. I do if I think they've got a significant enough varus deformity in the leg. This dog's angles, like its anatomic lateral distal femoral angles were 99 and 98 degrees, so really not appropriate for a correction in terms of a wedge. With the rotational change, which I mentioned, I generally do this first, and if it reluxates, consider doing an osteotomy for the rotation. Most of the time you can get away without doing something. Although I did have a dog recently that we've been working on that ended up needing to have that rotational issue corrected to actually resolve the recurrent luxation.
Was that the one I saw this morning?
Cujo?
Yeah.
No, that was a different one. We've actually been doing a bunch of distal femoral osteotomies lately. I did one last week on a 3-legged dog, which made the stakes a bit higher. You don't want to screw that up.
She's doing great.
But she's doing really well today, which is good. So I'm just closing the joint capsule first. So we have given it a bit of a flush. And then we're going to do an imbrication in the fascia as well. I don't. Can I get some 2O PDS, please? So you remember we took the biceps fascia off and it attaches on the tubercle of Gertie. So I'm actually going to run my scissors up here now. Take off probably 4 or 5 mil all the way up. So that's my section of the fascia that's come away. And then I do these in a cruciate pattern.
And a vest over pants?
No, I'm not a vest over pants kind of guy. I don't like to tuck my shirts in.
I just like the name.
I know, it's a good name. So I do this imbrication by literally just resecting a section and doing a appositional pattern in the biceps fascia. As Sarah's pointed out, you could do a vest over pants. Actually, I'm going to cut both of those. So I tell you what, guys, I'm going to finish this here, and then I'm actually going to probably end the live stream and just motor through this second side. And if I get through it quick enough, I might be able to live stream a splenectomy in a few minutes' time in here. So if you guys are happy with that deal, rather than just show you both patellas and I get in trouble with the nurses for taking too long and chatting too much. Let me know what you guys think of that deal. silence.
Take that as consensus.
Why not? So just close this fascia all the way down to the insertion on to tubular gertie, but we can actually pull this over a little bit just to try and get a bit of coverage of these implants. It's Friday afternoon here in Melbourne. I hope everyone's doing something nice for the weekend. I'm certainly looking forward to the weekend. We've had a pretty busy week this week. Sarah's nodding her head in agreement. We were supposed to do 2 hip replacements. We only ended up doing 1 because one was coming from Tasmania and cancelled and rescheduled till February because she couldn't organise flights.
This time of year is not great.
No, it was pretty difficult. Okay, so that's all done. We're now going to close the sub-Q. No, I don't think it needs a release on the medial side. Generally don't do a medial release unless it's like a grade 4. So I'm going to grab this fascia that's just under the skin of my next layer. It's called the lateral geniculate fascia. Oops.
Got some tape, isn't Medial?
That's good. So if you guys have any questions, sing out. We're just closing up here, and we're going to probably wrap this live stream up in just a second. As I said, we've got a splenectomy that's going to come in this OR next, so I'll live stream that one as well for you guys. Has the splenectomy had CT yet, Jess?
No, they were going to knock it out in 10 from when I was talking to Haiti.
Okay. And is it, what's it had workup-wise so far?
It's had bloods, coags.
Any imaging there?
It had x-rays.
Yep.
And they could see
Something.
splenic mass. And it had chest x-rays as well, and they couldn't see any obvious mass.
Okay. So it might be a surprise.
Yeah. It's pyrotic as well.
Okay.
But otherwise, its PCB's 32, so
Yeah.
very reasonable. Had
So
a
it's not
bleed.
ruptured?
Oh no, it had a possible bleed 3 days ago.
So there's a question there, do you think leaving the medial joint capsule open from releasing can actually cause a problem? Look, sometimes there can be a large amount of swelling under the skin when you leave the medial joint capsule open after you've done a medial release, especially when it's a really aggressive medial release. The other thing that can happen sometimes, if you overdo your lateral imbrication and then you do your medial release, you can cause a lateral luxation of the patella. I've definitely seen that happen before. So yeah, leaving it open on its own though, apart from the swelling, yeah, I don't think it causes too much of an issue mostly. The swelling typically gets better with time. Okay, Jess, we might end this stream there. So I really appreciate you guys coming in. I'm going to try and live stream this splenectomy in about probably half an hour to an hour's time. So feel free to tune in. I'll see you all soon. So I'm just going to move this so I can see.